Speaker is Professor Amjad Pervaiz Cheema. The professor is a colorectal surgeon with special interest in rectal cancer surgeries. He's the professor of surgery at University of Portsmouth, UK, and director of European Academy of Robotic Colorectal Surgery. The professor is also chief of colorectal surgery at Champalimaud Foundation, Lisbon, Portugal, and head of robotic program at Hamad General Hospital, Doha, Qatar. Professor, I welcome you here on stage.
अस्सलाम वालेकुम, बहुत शुक्रिया आपकी इनविटेशन का। और ये पहली दफ़ा नहीं है, मैं 2-3 दफ़ा पहले भी आ चुका हूँ। अमजद सराज साहब और उनकी टीम का और all these people who've been around. It's always a pleasure coming and speaking and training people. बहुत लंबा सा इंट्रोडक्शन की ज़रूरत नहीं है। मैं कोलोरेक्टल सर्जन हूँ, मेरा इंटरेस्ट इन्वेसिव सर्जरी में है और मैं इंटरेस्टेड हूँ टीचिंग और ट्रेनिंग में। So what I'm going to present to you is based around perhaps my journey of about 20 odd years of sort of going around and teaching and training people. And what I probably would like to sort of highlight is that how training works. And I think this first little debate about getting people from outside, this is a different country, this is a different culture, I've been hearing it for the last 15 years. I come to this country every year and everybody comes up with this. एक इंटरेस्टिंग चीज़ जो डॉक्टर साहब ने यहाँ से कही थी कि पहली चीज़ एक्नॉलेज करना है कि हमें सीखने की ज़रूरत है। तो मैं उर्दू में इसलिए बात कर रहा हूँ कि मेरा ख्याल है कि आप सब लोगों को उर्दू आती है, तो इसलिए मतलब मेरा ख्याल आसान हो जाएगा आपको समझने के लिए। कभी आपको लगा है कि इतने 500 साल पहले ऑटोमन्स वर द बिगेस्ट एम्पायर, नेवल एम्पायर्स, चाइनीज़ वर द बिगेस्ट नेवल एम्पायर्स, ठीक है। लेकिन वाई इट इज़ सो कि स्मॉल नेशंस लाइक Portugal, Spain, they discovered the far-off places, not Chinese dynasties, not Ottoman empires. हालांकि उनके पास नेवी भी थी। प्रॉब्लम ये था कि जब उनके पास कोई सजेशन लेके जाता था कि मे बी यू शुड इन्वेस्ट इन रिसोर्स डेवलपमेंट, नई जगह देखो, नया नॉलेज ऐड करो, तो उनका कॉन्टेक्स्ट ये होता था कि वी आर ऑटोमन्स, वट एवर इज़ आउट देयर वी नो दिस, हमें इसकी ज़रूरत नहीं है। सो दैट वाज द रीज़न कि जो लोग जिन्होंने फार ऑफ प्लेसेस डिस्कवर की और फार ऑफ प्लेसेस में जाके काम किया, दे स्टार्टेड विद फर्स्ट थिंग कि जब उनसे कोई सवाल पूछा जाता था, दे वुड ऑलवेज से, अगर उनको चीज़ नहीं आती थी, कि आई डोंट नो द आंसर, बट दे फॉलोड इट अप विद अ वेरी इंपॉर्टेंट सेंटेंस आफ्टरवर्ड एंड दे सेड बट आई वुड लाइक टू लर्न, शो इट टू मी। यहाँ से लोग पुलों के डिज़ाइन लेके गए जो अब 17th-18th सेंचुरीज़ में जो ब्रिटिश म्यूज़ियम में लगे हुए हैं, घरों के डिज़ाइन लेके गए, हाथ से बनी हुई तस्वीरें हैं, दिस इज़ द डेटा दे टुक फ्रॉम हेयर। तो हम सारे कहते तो ये हैं कि हमारी चेंज इधर से आएगी, हम यहाँ से सब कुछ चेंज करेंगे। अगर इतने सालों से हो नहीं रहा तो थोड़ी देर के लिए रिफ्लेक्ट करने में क्या हर्ज है कि प्रॉब्लम हम में है, बजाय इसके कहना कि बाहर से लोग आएंगे, बाहर से लोग इम्पोर्ट होंगे, वो ये करेंगे। बाहर से लोग आके आपको गोल पोस्ट दिखा सकते हैं, चेंज यहाँ से आपको खुद करना है। अगर इतना ही सारी ऑनेस्टी है और हम सारे इंडिविजुअली इतने ही रिफ्लेक्ट करते हैं इस चीज़ पे कि हम सब इम्प्रूव करना चाहते हैं, तो वाई इज़ इट सो कि यहाँ पे अब तक ये चीज़ डेवलप क्यों नहीं हुई 15 सालों से? सो जस्ट सिर्फ थॉट फॉर रिफ्लेक्शन बिफोर आई स्टार्ट। चलो अब देखते हैं कि इफ़ वी कैन होपफुली शो यू समथिंग। ओके, सो यू हैव अ पिक्चर? ओके. So I started my journey in this place. This is Portsmouth. This is south coast of England. 2006 I started here. I trained in Wessex region. I took a job here. इसलिए मैं आपको थोड़ी सी हिस्ट्री का कॉन्टेक्स्ट देना चाहता हूँ कि लोग अमूमन एंड रिजल्ट देखते हैं, मतलब लोग देखते हैं कि प्रोफेसर सो एंड सो यहाँ आ गए हैं, ही ऑलवेज हैड इट लाइक दिस, थिंग्स वर ऑलवेज लाइक दिस, ये एक प्रिविलेज जगह पे काम करते थे तो शायद इनके लिए बहुत आसान था। तो टू पुट थिंग्स इन कॉन्टेक्स्ट फॉर यू, दिस इज़ अ फैंटास्टिक प्लेस बाय द वे। आजकल मैं 2 वीक्स यहाँ गुजारता हूँ। दिस इज़ चैम्पैलिमो फाउंडेशन इन लिस्बन, विच मोस्ट ऑफ यू आर वेलकम टू कम। ट्रेनीज़ के लिए ओपन इन्विटेशन होता है। वी रन ट्रैवलिंग फेलोशिप्स, free of cost, and this foundation pays for travels and accommodation as well if they get into research attachment. और 2 weeks में यहाँ गुजारता हूँ. This is Hamad Hospital in Doha. I'm helping them learn robotics and laparoscopy. So, to give you a context, क्योंकि हम लोग सारे laparoscopic surgeon हैं, laparoscopy करना चाहते हैं, because this is the sexiest thing to do. This is, you know, if you're not doing laparoscopy, you're not in the group. Generally concept ये है. ये concept गलत है. Laparoscopy is just a tool. It's not a religion. Religion really is anatomy for surgeons. मुझे कुछ लोग अपने तस्वीरें भेजते हैं, samples, specimens की videos भेजते हैं because they wanted to sort of show this. ये इस मुल्क से भेजी हुई एक तस्वीर है. आप लोग इस तस्वीर को शायद देखे हों, आप लोग मीडिया पे शेयर करते हैं ग्रुप्स में. Somebody sort of said कि we would really like your comment on this because this is the first laparoscopic APR we have done. Or if I look at it, I say it looks all right from outside except perhaps the stroma is a bit lateral. Other than that, it looks okay. So I asked them to send me a picture of the specimen because I really wanted to look at the picture, because as a cancer surgeon, the focus really is on cure rather than just cosmesis alone. And most of you would agree that this is perhaps a suboptimal picture for a cancer oncology resected specimen. So for young people sitting in the audience, learn anatomy. Anatomy is the key. It's the key that would sort of dictate how good or bad you would become. And then use mere tool of minimally invasive surgery, be it laparoscopy or robotics, to achieve that anatomical dissections. It started by this guy. This is a French guy who did the first lap coli in 1986 or 87. I think they started it. And you could see how things have changed in the last sort of 3 decades or so. This is 2006, my first week in Portsmouth as a colorectal consultant surgeon. ये जो स्टैक आप देख रहे हैं, इस पे ब्लू और वाइट पिक्चर नज़र आती थी. कलर स्टैक नहीं था ये, क्योंकि स्टैक ख़राब था, वुल्फ का स्टैक था. Nobody was interested in laparoscopy. और जब emergency people used to come and take this stack because they wanted to do lap appendices. So my fellow and registrar used to come 6 in the morning, try to get this stack so we could at least do lap case. तो उस वक्त भी हमारे कुछ सीनियर सर्जन थे जो मुझे कहते थे कि इतनी मुसीबत क्या है, तुम ओपन कर लो. ओपन भी तो कर रहे हैं. तो एक आइडिया तो ये था कि मैं उनकी बात मानता और ये सब कुछ करता. दूसरी चीज़ ये है कि if you genuinely believe कि इसका पेशेंट को फ़ायदा है, this is where the goal post is, where the goal post is going to move, then you sort of stick to it, and then you sort of put an effort, you commit to it. This is Asha Senapati with her head behind. So जो मेरी senior consultant colleague थी, she became president of ACP afterwards. मेरे पास कोई ट्रेनी नहीं है, देखें इस पिक्चर में, because nobody was interested कि ये 6-7 घंटे लगाएंगे, पता नहीं ये क्या करेंगे. हालांकि उस वक्त 6-7 घंटे नहीं. I had sort of come in as a trained fellow after sort of doing the fellowship for Royal College of Surgeons. So this was a paper published in BJS from Robin Kennedy's and Yovel group. I was an SR working with him at the time. And this created a lot of problem. BGS published it where he claimed, or we claimed, that our practice showed that over 90% of our elective colorectal cancers were done laparoscopically. With due respect to Professor Sub, not in a big teaching hospital in Bristol. This is Yeovil, the smallest trust in UK. 90%. And I worked with him for 3 years, so it was a true data. I know that he didn't make the figures up. We came to Portsmouth, 2005 I got appointed, end of 2005. This is an older slide to show how open surgery went down to under 10%. This is 300 plus colorectal cancer, all-comer practice, not choosing it. This is the data for 8 years or so. This has been published, by the way. This is not a sort of solitary slide that I'm showing you. Over 1,600 or nearly 1,600 cases, conversion rate of 3%, R0 resection rate of 98.7%, length of stay 4 days. Started with that single stack. 5 surgeons got trained. All my colleagues got trained. Some of them did this better than me. And I have shown it, no shame in admitting that some of my trainees did it better than me. एक जनरल कॉन्सेप्ट होता है कि ये हाई रिस्क मरीज़ है, बूढ़ी औरत है, इनको कार्डिक इश्यूज है, जल्दी से कोई ओपन ऑपरेशन कर दें. ये एक रिकरिंग थीम थी which I felt as a trainee. Everybody used to tell me, I can do the right hemi with a transference and it takes me about 45 minutes. This is publication Annals of Surgery from our group, where we looked at high-risk patient in 2 years' time that we worked in. High risk included people who were 80 and above, ASA grade 3 and above, who had pre-operative chemoradiotherapy, T4 tumor, and BMI of over 30. This is pretty high-risk group, really. And we compared LAP and open surgery in our department, done by 2 very experienced open laparoscopic surgeons who were the senior consultants and 3 laparoscopists who were trained within the unit. So we showed that we had shorter hospital stay, better complication rate, reoperation rate, and readmission rate was slightly higher. So it shows that it is not only possible to safely do it, perhaps you improve the outcome if you apply minimally invasive surgery to this. And this has been shown in a number of trials. I don't need to sort of give you the run of classic colored trial, Korean trial, Spanish RCT done by Barcelona group, showing all this. So इसको लड़ने का कोई फ़ायदा नहीं है. ये मैं आपको यहाँ बैठे लोगों को बता दूँ कि ये डिबेट है ही नहीं. कोई आपको ये कहे ना कि ओपन सर्जरी is trying to sort of stick to the relevance. Don't stick to this. See where the progress is. तो ये आना ही आना है. ये आज आए, कल आए, हफ्ते भर में आए, साल में आए, ये आएगा. ये revolution यहाँ पे भी आएगा. This is no exception. So लोग सीखते हैं, people improve. This is classic trial. We were contributing data in UL for this trial. ठीक है? Precondition क्या थी? आपने 20 केस किए हुए हैं. You are expert. You can contribute into this trial. And this trial showed that they had 34% conversion rate for rectal cancer, 25% CRM positivity rate in rectal cancer. Okay? This trial get quoted all around the world for the last 20-25 years. I've been going around the circuits and, like people like to defend this trial. People who are against laparoscopy like to hang on to this trial because this is their relevance. People have this group have published the long-term data now that even with 25% CRM positivity rate, there is no worse long-term outcome. Then this is color 2. 5-10 सालों में वही group improve हो गया जो 20 cases किए थे अब उन्होंने 100 किए 600-700 cases किए for example. Suddenly the conversion rate goes down, CRM positivity got better. तो कुछ तो हुआ है ना. अगर वो पहला ट्रायल देख के कहते कि भाई ये हमारे बस का काम नहीं है, ये हमारा रेवोल्यूशन नहीं है, हमें इससे कोई लेना देना नहीं है. Progress doesn't work like this, I'm afraid. Look at this. This is Korean trial. Mid to low rectal cancer, T3 tumor, locally advanced, post-chemoradiotherapy. Look at the conversion rate, look at CRM positivity rate. और मैंने वो slide थोड़ी काट दी है, but you can look at this paper, even showing better survival outcome in laparoscopic arm. क्लू क्या है? क्लू ये है, just to give you an idea, ये trainees के perspective से मैं बता रहा हूँ अब. The clue really is to standardize your care. Operative technique is just one component of care. Previous speakers spoke about MDT concept. मेरे ख्याल में this is a crux that holds the cancer care back in this country. Radiology improve करें. We go on the basis of somebody sort of saying there is a thickening seen on rectosigmoid junction. Tumor आप finger पे feel कर रहे हैं, उनको rectosigmoid के ऊपर thickening नजर आ रही है. So this is a gap that we have to bridge, whether we like it or not. This is a consensus paper we published a few years ago trying to standardize laparoscopic TME. हमारे अपने outcome कहाँ हैं? This is a three-center data, rectal cancer का. We showed, have a look at this. This is a 5-year overall survival rate of about 83%, disease-free survival, stage by stage, very respectable, with local recurrence rate of under 2%. This is all comers practice. Only 23% of the patient had chemoradiotherapy. ये नहीं है कि सबको रेडियोथेरेपी दे के फ्राई करके स्टेराइल कर लिया और उसके बाद ऑपरेट किया. And there is nothing magical about it. This two sort of slides you see, AP is my practice in Portsmouth. 3 different essential initials on the other side are my trainee at the time. One of them is sitting in this room. ये उनका combined data है जब वो consultant बने और अपने independent practice में गए. Exactly the same figure as they had it in the mother unit. So it is not only just, there is nothing special about it कि सिर्फ मैं कर सकता हूँ. There is no man in this. जो concept है ना training का, उसके लिए सबसे ज़्यादा important चीज़ है कि person who is really interested in teaching and training, he or she would be willing to progressively become irrelevant. Hang on to this thought. ये बड़ा मुश्किल है. हम सारे relevance चाहते हैं. हम चाहते हैं कि हमारी चुदराहट बनी रहे. मेरा ट्रेनिंग मुझसे अच्छा कर लेगा तो फिर मेरे आने का यहाँ क्या फ़ायदा है. ये प्रॉब्लम ये है सारा. जब आप जाओगे तो थोड़ी देर के लिए रिफ्लेक्ट करोगे तो तुम्हें काफ़ी सारे आंसर मिल जाएंगे. So this is the concept. Concept क्या है कि आप जहाँ भी सर्जरी कीजिए, लेप्रोस्कोपिकली कीजिए, रोबोटिकली कीजिए, एशिया में करें, यूरोप में करें, अफ्रीका में करें, your specimen should look consistently the same, you know. And this is what is a surrogate marker of our care. This is what your show off, जो लोग कहते हैं ना, show off वो नहीं है जो लोग करके दिखाते हैं. Show off ये है जो specimen निकलता है और आपको अपने आप को सेल्फ क्रिटिक करना है स्पेसिमेन की बेसिस पे, ऑनेस्टली. ये नहीं कहना कि ऑपरेशन ख़त्म हो गया, स्कार बार से नज़र नहीं आ रहे. दिस इज़ व्हाट मैटर्स टू पेशेंट. रोबोटिक्स, सेम थिंग. Revolution came in 2013-14 in Europe. We were part of that. This is publication in Jamil Ahmed, who was our fellow at the time. He published this first 100 cases. SI system, जो यहाँ पे system है, इसको लोग कहते थे कि जी इससे स्प्लेनिक फ्रैक्चर मोबिलाइज करना बहुत मुश्किल है, पेशेंट फिक्स हो जाता है, इसमें व्यू का प्रॉब्लम है. People were doing hybrid techniques. They were doing all sorts of things. There is no need for it. So what did it show in our data? We showed that you have better urogenital nerve function score when you compared laparoscopy and robotics. We showed that it is possible to have better short-term outcome in obese and super obese patient. By the way, this has been shown in rollout trial, be it not like statistically significant, but they could see it. फिर ये एक पेपर कोलोरेक्टल डिजीज़ में हमने पब्लिश किया कि which showed that high risk group even done by robotic surgery have better outcome. तो बायोलॉजी तो चेंज नहीं ना हुई, एनाटमी चेंज नहीं हुई, टूल चेंज हो गया. और टूल चेंज होने से ये हुआ कि यू बिकम बिट मोर प्रोफिशिएंट. सो हाउ कैन यू रिड्यूस दिस? लेट्स गेट टू द क्रक्स ऑफ इट. आपको मैंने डेटा दिखा दिया वेयर द गोल पोस्ट इज. अच्छा, बिफोर आई गो, ये इंपॉर्टेंट चीज़ और है कि जनरली हमारा ये कॉन्सेप्ट है, मैं with the permission of the chair people sitting here, मैं बहुत सालों से पाकिस्तान आता हूँ because I have extreme loyalty to this country. और मैं कोशिश करता हूँ कि मैं कंट्रीब्यूट कर सकूँ जिस तरह भी करूँ. जनरली लोग मुझे ये कहते थे कि हमारे पास रोटी खाने की मतलब वो जगह नहीं है, आप हमें केक खिलाना सिखा रहे हैं. जनरली ना जब नहीं करना होता ना, दिस इज़ द फ्रेज दे यूज़. और जब कुछ ठीक हो जाता है और कुछ लोग सीख जाते हैं तो फिर वो इकबाल साहब का एक शेर है कि ज़रा नम हो तो ये मट्टी बड़ी जरखेज़ है साकी. इस शेर को सुन सुन के मतलब मेरे कान पक गए हैं. जनरली दिस इज़ व्हाट पीपल हाइड बिहाइंड. ठीक है. हाउ डू यू रिड्यूस द लर्निंग कर्व? इंपॉर्टेंट चीज़ इज़ कि you should have consistent and standardized technique to show you. My operation should look predictably the same every day of the week. Then my trainees can appreciate what normal look like. Then you would be able to appreciate what abnormal is. ठीक है, ये important है. दूसरा ये है कि I should have a technique which everybody else could reproduce. There is no point me dying with this that I'm so special that nobody else could do it. Then perhaps it is not a technique that is applicable to general masses. And if it looks good, it usually works. And the other thing I learned from Amjad Siraj Saab कि कराची के लोग थोड़े intellectually improved हैं as compared to the rest of the Pakistan. So let's put you to the test. What do you think is this place? It could be अगर इंग्लैंड कुछ लोग आए हों. कराची तो नहीं है ये. What? Third Parker? Okay, fair enough. What do you think is this? ये कराची नहीं है, ये तो मुझे पता है. What do you think is this? Russia, Moscow, you know? Why do you recognize this particular thing? The truth is, this all three pictures that I have shown you are within 3-kilometer radius in central Moscow. First picture I took in 2011 on my way from the airport. First time I went to Russia. तो मुझे बड़ा ग्लूमिंग दिन था, मैंने तस्वीर खींच ली. Rest of the time are from the internet. फिर मैंने गूगल पे देखा तो ये 3 किलोमीटर के रेडियस में है. Why do you recognize this? Because this is the pattern you have seen. This is the picture, it is in your memory bank. Or that's why I go on about having a consistent, standardized pattern recognition approach so people can appreciate what it should look like. So, आपको मैं अब 3 एग्जाम्पल दूंगा ट्रेनिंग प्रोग्राम की in 3 different parts of the world to put across the message that how it is possible to generalize it, and it is not only for privileged few that they are able to do this. This is UK, which is my second home. और डॉक्टर साहब ने जो मुझसे पहले प्रेजेंट कर रहे थे, he sort of shared some of this. This is a national training program, resource fill country over 12 million indirect and direct costs in investing into training their people. उनको भी ज़रूरत थी सीखने की, even resources के होने के बावजूद, इतना सब कुछ होने के बावजूद. So how they started like this. You don't go around and train people in Ladkana, Sakhar, Gujarat, Gujranwala, Attak. You put regional centers and make them to a level where they can train the districts. That's the key, in a way. And this is how they started. So they had a steering group, then they picked up national training centers. Generally, there were about 10 or 11 dotted around England, and then people were asked to register into the program. Putting any effort into any training program is to be underpinned by competence assessments objectively. It can never go on कि अमजद साहब मेरे दोस्त हैं, मैंने 2 केसेस करवा दिए और उसके बाद कहा कि मेरा ख्याल है आप ठीक हैं. मतलब जरा मैं उनको ये नहीं कह सकता कि वो चीज़ इम्प्रूव नहीं कर पा रहे. Important thing है, you must have objectivity attached to your assessment. This is how it went. The people were assessed as they were trained with a global assessment score sheet. People were scored on each module of the operation from 0 to 6, and that produced a data which was looked up nationally. You can look at it on an average. It took 22 cases for people to have a flattening of the curve where they could do procedures safely. So you got to put science behind it. You got to put objectivity behind it. When they finished their X number of cases under supervision, they were asked to submit 2 unedited DVDs, which were assessed by central committee blindly before they were able to deem competent or incompetent or resubmit for that matter. This is the data coming out of the program. This is volume, training center volumes, and so forth. And this was the impact at the time when this lab course sort of kicked off. Within 4-5 years, 45% of all colon and rectal cancer in England were done laparoscopically. The figure stands now around 68-70% in UK. So it does have implication. It is possible to reproduce this. It is possible to propagate this. अच्छा, अब वो इंग्लैंड है, मतलब अल्लाह आलम क्या खबरें हमें दिखा रहे हैं, स्लाइड दिखा रहे हैं, मानने वाली बात है भी कि नहीं. दिस इज़ पाकिस्तान, दिस इज़ हेयर. इसी मुल्क में रहते हुए कुछ लोग वो सारी चीज़ें जो हमने टॉक के शुरू में की थी, दे हैव अ डिफरेंट माइंड सेट. दे आर प्रिपेयर्ड टू से यस आई डोंट नो, टीच मी. दिस इज़ वन सच ग्रुप इन लाहौर. ये शौकत खानम का डेटा है, ये मेरा डेटा नहीं है, ये उनके लोगों का डेटा है जिन्होंने मुझसे काम सीखा और मुझसे अच्छा रिजल्ट प्रोड्यूस किया. आई थिंक वन ऑफ देम इज सिटिंग हियर समवेयर. This is their data when they change from open surgical technique to laparoscopy in right colon cancer. They were able to show not only better short-term outcome, जिसके ऊपर सारे लोग emphasize करते हैं, it showed better survival function, stage by stage. Stage 3 had a significantly improved survival. ये नहीं है कि वो अच्छे surgeon एकदम बन गए. They started selecting well, they started learning the anatomy. They had less morbidity in laparoscopic arm, which means that the stage 3 patients were able to get to chemo in time, and that have an influence in improving the survival as well. This has happened in this country. ये कोई बाहर की बात नहीं मैं आपको कर रहा. इन लोगों का आप डेटा देखिए. वजह सिर्फ ये है कि they are willing to say कि हमें कुछ सिखाए आके और हम उसको reproduce करेंगे. वो अपने लोगों को आगे से सिखाते हैं. One such unit is trying to do this here in Karachi, and I'm sure there are other units as well, Peshawar, capital, and so forth. This is Serbia. किसी ने नाम सुना हुआ इस मुल्क का? Good. One of the guys saw me in Moscow and he came to me and said, okay, I've just seen you operate and you come from England or whatever. Come to my country. We would like to learn this from you. तो मुझे देखना पड़ा कि सर्बिया है का. मेरे ज़हन में यही था, वो जो बैल्कन वॉर थी. So I went to the place. सुबह हॉस्पिटल जाना था तो मैंने कहा कि गाड़ी आ गई है. तो उन्होंने कहा हमारे पास तो यही है इस शहर में. दिस इज़ अ पेनचीवो. दिस इज़ आउटसाइड बेलग्रेड. I want you to sort of remember this and put this into context. When people have a will to do something, when they are prepared to accept that I need to learn how change happens. हमने इस ग्रुप के साथ 6 दफ़ा मैं गया एक साल में. हम सामान भी बाज़-औक़ात लेके जाते थे. Or we put them through this, we bring them to the level where they independently did 100 cases and they presented in the National Congress. 100 laparoscopic resection, small district hospital in Panchivo. The health minister got their attention and said कि ये तुम एक छोटे से अस्पताल में कैसे कर रहे हो, हम तो teaching hospital ये वो. He said कि I've got a friend in London. उनका ख्याल है इंग्लैंड में सिर्फ एक ही जगह है लंदन, तो वहाँ से वो आता है और हमें सिखाता है. So he asked me to come and spoke to me and said, can you not reproduce this in the country? So they set up this LabServe program, which is the same replica of LabCo, कि आप 8 training center develop करें, 16 surgeon, उनको उसी process से गुजारें stringently, objectively, and then ask those 8 centers to train the districts. It required commitment, it required series of workshop, it requires you visiting a lot, people are putting up cases, making sure that they work. उसमें और बहुत से लोगों ने मेरी हेल्प की. अकेला मेरा काम नहीं है. मेरे को दिस इज यान कुजू हु केम हियर एंड डिड दिस. आखिर में क्या हुआ कि 8 से शुरू हुआ, 40 contributed now. This is their publication. अब अगर आप देखना चाहते हैं, over 1600 cases done in 2 years by the country, which had nearly 0%. अब sporadic 2-4 लोग करते थे, ये उनके आउटकम है. Just as good as LabCo. इस पे इन्वेस्टमेंट क्या है इस प्रोग्राम पे पता है आपको? इस इन्वेस्टमेंट, इसमें कुछ डिनर्स हैं जो उन्होंने मुझे लेके गए, मेरा एयर फेयर है और एक कमरा सुलाने के लिए, बिकॉज दे वर कीन टू डू दिस. यू नो, it didn't require 12 million pound as UK invested into their program. क्योंकि nationally वो लोग चाहते थे कि अब improve हों. Now they are the central country in Balkan trying to train people in Croatia, Poland and Bosnia. Just finish off by showing this with robotics. It is not only laparoscopy, it is robotics which holds the same ethos. This is a group in Poole, Tehseen Qureshi, and then in Lisbon. When 3 surgeons were put through the test, same way when we looked at their Kusum curve score of gaining competence, and we were able to demonstrate this. 3 surgeons did 10 supervised cases under supervision, then went on to become independent, did 50 cases, similar outcome. Go on to Europe, not only a small centers. This is a European program run for robotic colorectal surgical training. अब इनको ज़रूरत क्या है सीखने की? इनको तो सब कुछ आता है. They are the world leaders, but they are willing to say that we need to learn. And that's what I keep going back, and I keep emphasizing this. The deal breaker is this mindset that I need to improve. और दूसरी एक चीज़ याद रखिए कि हम सब बहुत जल्दी बार सेट कर देते हैं. मैं बार सेट कर देता हूँ इस पे कि बस तुम यही कर सकते हो, यही स्टैंडर्ड है. वो वहाँ कहीं होता है, वो हमारे वाला नहीं है. I have absolutely no right to put a bar on somebody's brilliance and competence. I have had my chance, I've done a race, you know. उसका he or she has got their own run to do. और उनको इस छोटे mindset में कभी ना रखें. Tell them where the brilliance is. यहाँ से लोग जाते हैं, बाहर जाके इतना एक्सेल करते हैं, उनको वहाँ पर लग जाते हैं. ऐसा नहीं है, because they are given a fair run. और ये याद रखिए, जब आप ट्रेनिंग कर रहे हैं, goal post is not around you. Goal post is where the brilliance is, and this is what you need to see. This is the published data from that program. 26 centers, over 1,000 robotic colorectal cases. अब ये slide बहुत ज़्यादा है. Bottom line was this, कि when they were trained, they were able to reproduce the same outcome as the proctors and the trainers who trained them. I'm sure that you all want to look at this slide now. So MII surgery, in my belief, there is no debate. You know, there is no such debate as कि laparoscopy पता नहीं आएगी नहीं आएगी. It is here and it's going to stay, whether I like it or not. It is possible to produce similar clinical outcome regardless of trainees' level if you have a consistent common denominator of how you train them and who's training them and which program is training them. Structured training in laparoscopy makes the learning curve shorter. Standardization of operative technique is a key. अब सब लोगों का emphasis robot पे है. I'll finish off by just saying this. Fashion है इस मुल्क में, हर अस्पताल में वो एक CMR robot है, वो लगाने की कोशिश कर रहे हैं. और ये bottom line क्या है बच्चे? Bottom line देखें ये है, anatomy is the same in Homo sapien and it hasn't changed in the last 250,000 years or so. अब ये जल्दी में change होनी भी नहीं. कैंसर का biology एक ही तरह है, tool different है. अब ये expect करना कि robot is going to come and it's going to do Bill Heal's operation for rectal cancer, it is like a felony really in a way कि ये एक fallacy है कि मैं कहूँ कि ये robot वो operation करेगा. Robot surgery would demonstrate marginal gains, and to improve those marginal gains, you have to really practice hard with high volume. अमजद साहब बहुत शुक्रिया आपका, आपकी टीम का, आप लोगों का शुक्रिया इतनी देर मेरी बात सुनने का. Thank you very much for having me.
Thank you so much. Can we have questions? 2 questions from the audience first. Anyone?
Thank you, Professor Cheema. You have enlightened us and showed us the way how to go around things. One thing which I feel we lack is accountability. I think if we are given a task and I'm not asked what results I have produced, then we are going to falter. And that's what needs to be introduced in our system. That should be accountability. What I was asked to do, I should accomplish it, and if I fail, what I have failed, I should be asked about it. I think that's where we lack.
No, I think you've hit it on the head. When as a young trainee, I was asked that publish or perish, you know. History, always remember people in the way it's been written, because most likely they have written it. That's the key, right? अगर आप अपना data नहीं रखेंगे, अपना data publish नहीं करेंगे, गेम आपको देखना है कि रूल्स ऑफ एंगेजमेंट क्या हैं. रूल्स ऑफ एंगेजमेंट ये है अपने लेवल पे सेल्फ क्रिटिक, ईमानदारी अपने से कि मैं जो करता हूँ इज़ इट वर्थ फाइल गेटिंग आउट ऑफ द बेड इन द मॉर्निंग. अगर नहीं है तो क्वाइटली टेक अ साइड ट्रैक, ठीक है, ये बस का बात नहीं. लेकिन अगर इट गिव्स यू अ रीज़न टू गेट आउट ऑफ द बेड इन द मॉर्निंग, देन यू मस्ट हैव अ डेटा टू बैक इट. सब लोग, एक जनरल परसेप्शन क्यों है वेस्टर्न हेमिस्फीयर में या जो डिफरेंट पब्लिश जर्नल्स हैं पीयर रिव्यू में, कि यहाँ से वो डेटा लेते हुए घबराते हैं क्योंकि दे डोंट नो कि कितना ऑथेंटिक डेटा है. ये नहीं है कि लोग यहाँ ईमानदार नहीं. देयर आर सम फैंटास्टिक पीपल हु वर्क्स इन दिस कंट्री, दे प्रोड्यूस एक्सीलेंट आउटकम्स. लेकिन फॉल्टर यही है कि डेटा नहीं रखेंगे, अकाउंटेबिलिटी नहीं है, ऑडिट का कॉन्सेप्ट नहीं है, एमडीटी का कॉन्सेप्ट नहीं. एमडीटी का मतलब ये नहीं है कि वो आपको मुझे बताती है कि कैंसर का ऑपरेशन कैसे करना है. दैट इज़ अ गेट कीपिंग मैकेनिज्म टू फिगर आउट कि अगर मेरे मार्जिन पॉजिटिविटी रेट 25% आ रहे हैं, दे विल स्टॉप मी एज अ सर्जन. ये बहुत ज़रूरी है. और इसके लिए मतलब if you ask me what is one magic pill that needed to improve cancer care in this country, it is the concept of MDT, it's the concept of training allied specialty around the surgeons.
I think you are so right about it. Once I did a locum in England. I was doing a locum consultant, and I was doing a locum of a person. He was a consultant surgeon, but he was sent for retraining because he wasn't getting the yield that was expected.
Yes.
And that's what I meant by accountability. I think we should be giving what we are supposed to give.
Thank you, Professor. Thank you for such a nice talk.
Thank you very much for putting up with me.